Hi, welcome to Do This, Not That. I'm Sue Self, licensed clinical social worker and behavioral health liaison manager for BJC Behavioral Health. In this segment, we're trying to understand and feel confident and competent when providing care for patients who exhibit suicidal behaviors. Suicidal patients are very often misunderstood and can invoke panic, fearfulness, and extreme caution on the part of healthcare providers. Suicide behaviors themselves are not a psychiatric disorder. Think of this as a coping method. I know this can be a strange concept, but consider this. Patients who express thoughts of or engage in behaviors with the intent of ending their own lives are often really trying to put an end to their psychological pain and their problems. They have given up on the idea that life will ever get any better, so much so that they're unable to continue to try and have lost hope.
I just can't do it anymore. I can't do it.
To tell the truth, it can get a lot less frightening when you've listened to and understand the patient. Two things will go a long way: assessment and a positive working relationship in which we do a lot of empathic listening. Not every patient who thinks or even talks about suicide will make an attempt, and not all of them need to be on psychiatric floors. You don't have to be a licensed mental health professional to help a patient in this kind of situation. If a patient is suicidal, you might observe unbearable pain, physical and/or psychological, signs of depression, the patient talking about wanting to die or to kill herself, expressed feelings of hopelessness or having no reason to live, feeling trapped or terribly alone, talking about being a burden to others, displaying extreme mood swings, showing rage or talking about seeking revenge, such as, "They'll be sorry when I'm gone" kind of statements, a prior suicide attempt. One of the difficult things about suicide risk is that it's a spectrum that ranges from low to immediate high risk, and determining where a patient's risk is on the continuum is not an exact science. So what causes someone to actually think about taking his or her own life? While some medication and medical disorders can cause depressive symptoms, suicide is frequently associated with chemical imbalances in the brain, addiction and early recovery from addiction, chronic pain, loss, sleep deprivation, alienation, guilt, and shame. So what do we do for a patient who has been thinking about suicide or perhaps even made an attempt? Remember that people in this situation can feel intolerably alone, as if no one understands, and that being understood is impossible. Establishing a positive, trusting relationship with a patient in this situation is more than half the game. I can't say that strongly enough. Be someone the patient can talk to and trust, not to judge. Remember that you don't have to have all of the answers or fix things. The best care you can give is to listen well. First, don't worry that talking about suicide with the patient will increase his risk or be suggestive. It just doesn't work that way. You may be the only one willing to have this conversation. Don't ask about suicide in the midst of gathering other information or completing other tasks. Don't try to talk the patient out of their feelings. Give them a choice of behaviors by offering options. Don't confront the patient or use guilt or shame to get them to see that suicide is not a good idea. Don't use cliches or platitudes such as, "Suicide is a permanent solution to a temporary problem." Be warm, genuine, and sincere. Seek to understand the patient's feelings and problems from his or her perspective, even if their problems seem solvable to you. Ask questions gently, without judgment, and without implying what you want to hear. When asking the patient a question such as, "What was going on when you decided to take the pills?" wait for an answer before you ask another. Once the patient has answered, respond with empathy, such as, "All of that sounds pretty overwhelming," or, A lot of people would be overwhelmed by that. Some questions to ask a patient are: suicide intent. What was the patient hoping for when they made the attempt, or hoping would be the outcome if they do make an attempt? How does the patient feel about the attempt now? Relieved, ashamed, more determined? If you get a short answer, ask for a longer one, such as, "Can you tell me more about that?" A desire to die. A lot of suicidal people have some ambivalence about dying. They just want the pain to stop. Ask about their plan. Does the patient have future plans to die? Ask about details and time frames. Greater detail and closer time frame generally mean higher risk. Previous attempts. This also increases risk. Psychological pain. On a scale of 1 to 5, 5 being the most emotional pain you've ever had, how are you feeling today? How about on the day you made the suicide attempt? Ask the same about physical pain if it's appropriate.
Good morning, Lou. I'm Lillian. Can we talk for a few minutes? It seems like yesterday was a really bad day for you, wasn't it?
Yeah.
When you took those pills, were you hoping that you would die?
I guess I was. At least a little bit. I just couldn't do it anymore.
Have you ever tried suicide before?
No, not ever. This is a mess.
It sounds like things were really getting to be too much for you. What was happening that you got to that point?
I lost my house. I've been so depressed. I haven't been doing well at home for a long time. And I've been turned down for so many jobs. I can't even look anymore. It was just the last straw. I haven't been good at anything for a long time. And my family needs better. And they'd be better without me.
How are you feeling about all of that this morning?
I don't know. I feel stupid. I'm so embarrassed. I mean, I couldn't even kill myself.
It sounds like you have been feeling a lot of emotional pain lately. And on a scale of 1 to 5, how much do you really want to die?
I guess at a 2, I guess. I mostly just want all these problems to go away. I want life just to get easier. I can't deal with it all. Something really has got to give.
And so that something was you.
That something was me.
I'll bet that sometimes it seems like things just won't get better. Do you think they will or that they could?
I don't know. It's just all been getting worse and worse for a long time. I don't even know why I'm so depressed lately.
You've been sliding down this hill for a good while now. Are you still thinking that you want to kill yourself?
I don't know what else there is. I mean, things aren't going to get any better, and I don't know what else to do.
Tell me about your plans to kill yourself.
I don't have a plan right now.
You're certain?
Yeah, I just don't know what to do anymore. I can't make life work, you know?
Once you've heard enough of the patient's story to understand, tell him or her that you do. You can convey understanding without condoning the behavior. For example, with all of these things going on, I think I'm beginning to see how you could feel so overwhelmed and ready to give up. I'm also hearing that you would like to feel better or more in control of things. This can turn the story in a new direction and allow you to introduce the idea of making other decisions and accepting help.
It sounds like a desperate situation, and your family does deserve a good life. So do you. If there was something else to do, would you consider trying it?
If there's something to try, I will. I've just been feeling so out of options. Tell me what that is.
What I'd like to do is call someone up here to talk to you about it. Because I'm not the expert on these things, but I've seen people who feel a lot like you do right now, and they get better. Could I do that for you? Can I call them right now and find out when they can come up to see you?
Okay. But I don't like people messing around with my head.
They're not going to be messing with your head. There's been enough of that going on, right? I understand that you feel pretty bad right now, and things haven't started looking up yet. But let's get the ball rolling and see if we can't move things in the right direction. I'll make that call.
You're right. It's time I do something that will actually help.
Can you make an agreement with me that you won't do anything to try to kill yourself without calling for me? I'll come in, I'll check on you, the sitter will be here. But if you start feeling worse, just promise that you'll call for me.
Okay.
Research tells us that even when we don't ask all the right questions or forget some things, when we establish a positive, working, trusting relationship with the patient, the likelihood of a positive outcome increases dramatically. Combining that positive relationship with a good assessment of risk and responding appropriately is the best plan of action. Keep in mind, you don't need to be a psychiatric professional to help a person through this. You just need to know what to do. Thanks for watching.